Hello and welcome. We are facing a new endemic in Europe and worldwide, which is diabetes mellitus. I'm here in Switzerland for the Cardiology Update Congress in 2015 and would like to introduce to you Francesco Cosentino from the Karolinska Institute in Stockholm, Sweden, who's one of the leading experts in the field of diabetes. The European Society of Cardiology has taken action in the field and has introduced new guidelines for the diagnosis, early recognition, diagnosis and treatment of diabetes mellitus. Looking to the guidelines, Francesco, is the glass half full or is it half empty?
Well, considering the guidelines, I think that it was already some very positive aspect that with this guideline we have offered to the practitioners an important document which is clarifying the whole issue. And I think that, as you say, impaired glucose tolerance and diabetes are growing to epidemic conditions in Europe and worldwide. And we know that coronary artery disease and diabetes is a common and serious combination. So I think that these guidelines is the first systematic approach to offering physicians the possibility to compare efficacy of different treatment and in order to treat and to diagnose and treat cardiovascular complication in the setting of diabetes.
Let's start with the diagnosis of diabetes. The earlier the diagnosis can be made, the better the conditions should be to treat the people or the patients affected. What do the guidelines tell us with respect to early diagnosis? What should we do? Are there good reasons to go into screening programs?
Yes, indeed. The guidelines have somehow make an effort in simplifying the diagnostics of diabetes and these glycemic conditions. In the general population, the guideline promote the use of risk scores for the early detection of impaired glucose metabolism. And we know we have in Europe, we are lucky because in Europe we have a very well and developed and validated risk score, which is the Finnish diabetes risk score. This score has 85% accuracy in diagnosing the 10-year risk of developing diabetes. So in general population, we should implement this score. If you get a low score, then you don't need to go any further in the diagnostic investigation. But if you get a high score, then it basically select individuals which are suitable to screening for glycosylated hemoglobin and fasting plasma glucose.
So when the diagnosis of diabetes has been made, what are the most important steps then for risk stratification of the patient and treatment of diabetes mellitus? What do the guidelines recommend?
I mean, it's very important, the cardiovascular risk stratification in the presence of glycemic conditions. Because these set the stage in individuals for high risk, intermediate risk or low risk. So we need to stratify, and in this regard we know that there are a lot of tools, diagnostic tools, biomarkers, emerging biomarkers, but such as the intima media thickness, the ankle brachial index, the coronary artery calcium score, cardiac autonomic neuropathy, to mention some. But this is still a gap in evidence, because most of these biomarkers badly perform if we compare them with the most traditional cardiovascular risk scores. So there is a lack of significant impact of these biomarkers. The added value is still a matter of debate.
When it comes to coronary artery disease, on the background of diabetes mellitus, when it comes to the necessity of coronary interventions, either bypass surgery or percutaneous angioplasty, what do the guidelines recommend in this direction?
This is an important issue because you have to think that almost 1/4 of the revascularization procedures are performed in patients with diabetes. First of all, you have to consider the complexity of the anatomical bed in terms of disease. So revascularization procedures, either PCI versus bypass grafting, the choice has to be based on the involvement of the coronary circulation. So for less complex disease, optimal medical therapy is still a very good approach. And we know that the extension of the coronary artery disease is not really great. Optimal medical therapy is the first approach. In case we have lesions, then percutaneous angioplasty is good for 1-2 vessel disease. Low symptoms with the LV function which is still preserved, but for multi-vessel, very complex picture, then you have to go for bypass grafting when there is a syntax score, which is a score which allows us to calculate the complexity of the disease. If you have a syntax score above 22, then bypass grafting is the choice.
That's a very important advice coming from the new guidelines. Francesco, I would like to come back to the very important field of prevention of diabetes mellitus, and I would like to briefly touch with you 3 different levels. I would like to ask you what individual people can do in order to prevent diabetes. Second question would be, what can or need physicians to do in order to promote prevention of diabetes? And third level would be healthcare politicians. So individual people, what would be your advice?
I mean, the lifestyle modifications are really one of the first strategy to be adopted in order to prevent the progression of this glycemic condition, which may be, you may be overweight, you have insulin resistance, but you are not yet diabetic. So in order to delay the progression towards the disease, you have to really have a very strong change in your lifestyle, in your dietary habits, because it's been proved by all the studies available that this is very effective in preventing the development of the disease.
Physical activity, sports, does that play a role?
Physical activity, of course, is part of the lifestyle changes. Physical activity is crucial, and in the guideline it is stated that you need at least half an hour a day of physical activity beside your changes of dietary habits in order to be effective. And then, of course, important is a multifactorial approach to prevent the complication, cardiovascular complication of diabetes. And in this multifactorial approach, you have to consider lipid control, blood pressure control, eventually antiplatelet therapy, if this is recommended mostly in secondary prevention. And so the main focus of the guideline is this multifactorial approach to the global cardiovascular risk, which is increase in patients with dysglycemia, in diabetic and pre-diabetic individuals.
How about the role of healthcare politicians? Looking to the, for example, European Parliament, is there anything that you would expect from this side to support prevention of diabetes?
I mean, of course, as we all know, in the prevention field, the preventive strategies are implemented much more in on a population base if the political stakeholders are supporting this implementation. And because we are aware of that within the European Society of Cardiology, we have a new office in Brussels, which is one of the mission of this office is to try to promote a kind of lobbying process in order to convince the European politicians to embrace the prevention strategies and to develop them in the different European countries.
Francesco, let's hope if we bundle forces, healthcare politicians, physicians, the European Society of Cardiology, to bring the people and patients on board in order to tackle the challenge of diabetes mellitus adequately and to reduce the burden of diabetes in Europe and beyond. Thank you very much for staying with us here at EHJ today.
Thank you.